Hello, today we will finish the topic of cell dystrophies and we will discuss disorders of extracellular matrix, mitochondrial diseases and peroxisomal diseases. We will start with extracellular matrix. Which components do we have here? There is some interstitial fluid, there is a fibrillary component, which means collagen, elastin, there is an amorphous component or ground substance, which means mainly glycosaminoglycans. So we can have disorders of interstitial fluid, disorders of fibrillary component, disorders of ground substance, and there can be also some new depositions of pathological substances that are normally not here, such as calcifications. But the first and the last one, these are slightly different topics and we will discuss them today. Today we will discuss disorders of fibrillary and amorphous component. Again, such diseases can be subclassified as acquired and congenital, and we will start with acquired ones. So the acquired disorders of fibrillary component of extracellular matrix. There is a fibrosis. What does it mean? Fibrosis means absolute increase of collagen in the tissue. Usually it's a result of healing of a single shot or chronic process. So it can be simple scarring after acute inflammation, after trauma, or it can be healing of a surgical wound. Or it can be fibrosis as a part of chronic process, chronic inflammation, autoimmune diseases, for example. So fibrosis basically means scarring. Hyalinization means consolidation of collagen fibers. So the collagen fibers became more dense. In light microscopy, hyalinized fibrous tissue is very hypocellular. There is not too much fibroblasts. It's eosinophilic and homogeneous. Hyalos in Greece means glass. So it has some sort of a glassy appearance. It stains like collagen because it is collagen. It's just more dense. In hematoxylin eosin it will be pink. In trichrome, for example, blue trichrome, it will be blue. In green trichrome, it will be green. And it often calcifies. Typical example is perisplenitis cartilaginea. Perisplenitis cartilaginea looks like multiple plaques and nodules on the surface of spleen capsule. But the term perisplenitis cartilaginea is wrong because it has nothing to do with inflammation, so it's not perisplenitis, and it has nothing to do with cartilage. It's just a degeneration of spleen capsule, and histologically those nodules are composed of hyalinized fibrous tissue of the capsule or corpus albicans in ovary. So you can see hyalinized tissues also physiologically in the patient's body. Opposite change is fibrinoid dystrophy. Fibrinoid dystrophy means loss of fibrillary pattern of collagen. It's basically a shredding of collagen, and usually it's caused by influx of plasmatic proteins into the interstitium. Very often it comes as a part of immunopathologic reaction, and if the fibrinoid dystrophy is severe enough, it can progress to fibrinoid necrosis in more severe cases. And fibrinoid necrosis, you know it very well from our previous lectures, and you know it often comes as a part of vasculitis, of immune-mediated inflammation of a vessel wall. Fibrinoid dystrophy stains like fibrin. In hematoxylin eosin is bright red. In trichrome it would be red as well. You can see it here. This is vessel wall affected by vasculitis, so there is a lot of inflammatory cells. And this eosinophilic band, this bright red band, this is fibrinoid necrosis of the vessel wall. So it was about the fibrillary component, and now about the amorphous component. Typical example is sclerosis. Sclerosis means relative increase of collagen in tissue. So the amount of collagen in tissue stays the same, but there is a loss of glycosaminoglycans. So it's just a relative increase of collagen. Typical example, degeneration of the skin in old patient. So simple senile skin degeneration. Ganglion is another example of storage of glycosaminoglycans. Ganglion is a small nodule, usually seen on a wrist, usually near tendons, and histologically it's a collection of glycosaminoglycans. We are not sure with the etiology. It may be post-traumatic, but we are not sure. And in the course of the time, the ganglion becomes encapsulated. So in the course of the time, the fibrous capsule around the deposition of glycosaminoglycans develops. And very often it needs to be excised surgically. Myxedema. Myxedema is generalized increase of glycosaminoglycans in subcutis. Typically, it can be seen on tides, but the deposition is generalized. It's just more pronounced here. And it's typical for patients with hypothyreosis, because in those patients there is a generally the metabolism in those patients is slower, and there is also, because of that, there is a slower turnover of glycosaminoglycans, especially in subcutis. So that's why those patients are prone to mixed edema. We shouldn't forget that the accumulations or depositions of glycosaminoglycans are part of degeneration of a vessel wall, especially aorta. It is not specific. It is not specific for any disease. It's a very general sign of degeneration of the aortic wall. And you can see it here on this picture. This is stained by LCN blue, and LCN blue stains glycosaminoglycans. So all those depositions that are blue are pathological depositions of glycosaminoglycans. And as I said, this is not specific for any disease. This is very general, and it's a general appearance of degenerated aorta. So you can see it as a component of atherosclerosis. You can see it as a component or as a result of inflammation. You can see it in some congenital or in some diseases which are associated with a congenital defect of aortic wall, such as Marfan syndrome, for example. These mucoid accumulations, of glycosaminoglycans can be found in tunica media. So it's a disease of tunica media especially. And again, I mentioned it many times, neoplasias. Neoplastic cells are damaged and they can store various substances, glycosaminoglycans as well. So you can see we can have a lot of tumors that are accompanied by depositions of glycosaminoglycans. Such tumors are called myxoid. So if you hear a term myxoid, it means that the tumor is full of glycosaminoglycans. Typical example, myxoid liposarcoma, but it's not the only one. And such tumors are very often gelatinous on gross examination. Now about the congenital disorders. Marfan syndrome. Marfan syndrome is autosomally dominant disease, which is caused by mutation of gene for fibrillin. And fibrillin protein, it's an essential component of elastic fibers. So basically there is a problem with elastic fibers, elastic component of extracellular matrix. The clinical presentation of those patients is quite typical. Those patients have a lot of problems with the musculoskeletal systems. They have scoliosis, very often thoracic deformities, flat feet, very often problems with eyes. Eye lens subluxation is very typical for patients with Marfan. And as a consequence, they develop myopia and very often accelerated cataract. Dolichocephaly, which means long skull. And another typical feature is a high-arched, so-called Gothic palate. The joints are typically hypermobile, which can accelerate arthrosis of those patients, especially in older age. And patients with Marfan have typical physique. They are very tall, very slim, gracile, with long fingers. The reason for this is that the microfibrils normally ensure or help to degrade tissue growth factor beta. And in Marfan syndrome, there is impaired structure of microfibrils because of the mutation in fibrillin. So also the degradation of tissue growth factor beta is impaired in those patients. And the tissue growth factor is accelerated. But the biggest problem is inside. So those patients have a lot of problems with cardiovascular system, especially with the valves. So very often they have prolapse of bicuspid valve, and they are prone to aortic aneurysm and aortic dissection, which is usually the most common cause of death in those patients. Ehlers-Danlos syndrome, this is not one disease, it's a group of diseases which are characterized by impaired collagen synthesis. So Marfan was about elastin, this is about collagen. The clinical presentation is typical as well. The joints are hypermobile, so again they are in a risk of accelerated arthrosis. Very typically, they have very hyperelastic skin. You can see it in every picture of the patients with Ehlers-Danlos. And again, the biggest problem is inside. So those patients are prone to vascular complications such as aortic dilatation, aortic dissection, or bleeding disorders. Mucopolysaccharidosis. Mucopolysaccharidosis, it's a group of diseases, inborn errors of metabolism of glycosaminoglycans. So mucopolysaccharidosis is caused by congenital error of enzymatic degradation of glycosaminoglycans. And glycosaminoglycans are stored, are stored in tissues which are normally rich in glycosaminoglycans, which means connective tissue, cartilage, and they are very often stored in endothelial cells and also macrophages because they are rich in lysosomes, and normally they help degradation of glycosaminoglycans. Such cells are histologically vacuolized, and the vacuoles are positive in Alcian blue because Alcian blue stains mucopolysaccharides, glycosaminoglycans. The clinical presentation of patients with mucopolysaccharidosis is very typical. Usually there is a psychomotor retardation, and also those patients are prone to accelerated cataract. They are small, with short deformed bones, because there is impaired endochondrial ossification. The subcutis of those patients is pasty, because the subcutis is full of glycosaminoglycans, and because of that they have typical facial stigmatization, because even the subcutis of the face is full of glycosaminoglycans, and the face has typical appearance. The patients usually have a big nose, big lips, and such stigmatization is called gargoylism. Usually they have a big belly because of the hepatosplenomegaly, but again, the biggest problem is inside. So those patients have a lot of cardiovascular complications like coronary diseases, valvular diseases, and they are usually the cause of the death. You should remember two most common types of mucopolysaccharidosis. Type 1, or Hurler syndrome, is autosomal recessive linked, and it is severe disease. It manifests usually around 6 months of age, And the patients usually die of cardiovascular complications around 10th year of life. Type 2 Hunter's syndrome is milder diseases, the clinical course is not so severe, and it's X-linked disease. Now briefly about mitochondria. Mitochondrial diseases are very unique. Why? Well, first, there is a maternal type of inheritance because all mitochondria come from mother. And also mitochondrial DNA is very sensitive to mutations. There are multiple reasons. For example, there is oxidative phosphorylation because there is a cellular bleeding in mitochondria. And because of that, a lot of free O2 radicals is exposed, and they are harmful to mitochondrial DNA. Also, the mitochondrial DNA doesn't have enough reparative mechanisms for that. And also, the mitochondrial DNA has more frequent replication rate compared to nuclear DNA. That's why majority of mitochondrial disorders are caused by mutations in mitochondrial DNA, despite the fact that the majority of the proteins in mitochondria is coded by nuclear DNA. The clinical presentation of mitochondrial diseases is very variable. The reasons are like that. First of all, there is a variable number of mitochondrial DNA copies, and also a variable number of mitochondria in different cell and different tissue types. Also, there is something called heteroplasmy, which means that during the cell division, mitochondria are distributed randomly to newly formed cells. And also the newly replicated mitochondrial DNA is randomly distributed to newly formed mitochondria. And a certain percentage of damaged mitochondria must be present for mitochondrial diseases to be clinically apparent. So there is a threshold effect. So you can see that there is a lot of reasons for mitochondrial disorders to be clinically variable. But usually the organs that are rich in mitochondria are mainly affected, which is CNS. Those patients often have oligophrenia, they are more prone to epilepsy, and very often they have problems with eyes. There is a retinopathy or optic neuropathy. The heart is very often affected. Those patients often develop cardiomyopathy or arrhythmias. They have kidney problems and skeletal myopathy. There is a lot of diseases, a lot of mitochondrial diseases. I will mention a few of them, which are probably the most common ones. You should remember Kearns-Sayre syndrome. Those patients usually manifest with muscle hypotony, with eyelid ptosis, with cardiomyopathy, and very common is pigmented retinal degeneration. Light syndrome, or called subacute necrotizing encephalopathy, is disease which is quite severe. It affects infants, and the children very often die in preschool age. And if you hear the term subacute necrotizing encephalopathy, it means that there is very often there are even necrosis in basal ganglia of the brain. And apart from that, there is usually severe muscle hypotony, impaired vision, and impaired hearing. Leber hereditary optic neuropathy is the disease very often associated with progressive loss of vision, and it usually manifests around second or third decade of life. And last but not least, we've got two syndromes, MELAS and MERV. MELAS and MERV are acronyms. MELAS means mitochondrial myopathy, encephalopathy, lactate acidosis, and stroke-like events. MERV means myoclonic epilepsy and the rigid red fibers, which means that the fibers of skeletal muscle are shredded in histology. So those acronyms, MERV and MELAS, they just describe the most typical clinical appearance of those patients. And last few sentences will be about peroxisomal disorders. Peroxisomes are quite unique organelles. They ensure metabolism of fatty acids with a very long chain. As a consequence, those very long chain fatty acids are stored in various tissues. They are stored in body fluids, or they can be found in body fluids, and they also incorporate into cell membranes. Because of that, usually the CNS is affected, the brain development is diminished or impaired, and usually a myelinization is also impaired. So the typical clinical manifestation is leukodystrophy. Very often it's accompanied by adrenal insufficiency. Those peroxisomal disorders can be subclassified to disorders of individual enzymes and disorders of whole peroxisomes, which is called peroxisome biogenesis defects. You should remember Zellweger syndrome. It is not one disease, it's a spectrum of diseases, so sometimes we can call it Zellweger spectrum. Those children usually have facial dysmorphia, neurological symptoms with oligophrenia, and severe muscular hypotony. And maybe you should remember X-linked adrenoleukodystrophy. And when you hear the term adrenoleukodystrophy, you know that the main clinical symptom will be, or the main problem of those patients will be leukodystrophy, which means impaired myelinization and impaired adrenal function. Okay, so that's all. That is the end of dystrophy topic. I hope it will be helpful for you, and see you soon.